Some have.
I'm not seeing your screen. I don't know if there. It's in the presenter mode.
All right, are we all good?
There we go.
Logistics of live and online meetings. So I know we have a mixed audience. A lot of you guys know you have sleep apnea, are already being treated maybe for sleep apnea, or wondering about other treatment options. And some of you may even know that there are multiple types of sleep apnea and that you have either obstructive sleep apnea or central sleep apnea. We're going to talk about those as we go through it. But we're going to start off just talking about sleep. How many people here get more than 7 hours of sleep at night? Me too. Here. How many people get between 5 and 7 hours a night? How many people get less than 5 regularly? So I want all of your driver's license. Give them to me right now. Can't be driving. So this is the recommendation from the sleep physicians and sleep professionals. Adults typically need between 7 and 9 hours of sleep. And we know that getting less than that is actually associated with a lot of health problems, but also poorer quality of life. And then there's such a thing as getting too much sleep. I don't believe it, but that's what I read. And I travel all over the country every week, so I'm chronically jet lagged, but I still, even in hotel rooms, try to get 7 or 8 hours of sleep every single night. So that's the recommendation. And what happens if you don't get that? So not getting good sleep, no matter what the cause is, can cause a lot of health problems. It can make you feel bad and cause fatigue. It also can cause high blood pressure. It can contribute to obesity. It can cause heart problems, headaches. It can cause strokes, lung problems, memory loss, and also problems with sex drive and erectile dysfunction. And that's just the impacts of poor sleep in general. We'll dive into sleep apnea here as we go through this. A couple of things about sleep deprivation, because I think one of the biggest misconceptions among clinicians or people taking care of patients and the medical community and the community at large is that being deprived of sleep or having sleep apnea just means that you're tired and sleepy. That's all it means, right? It's actually not true. We'll talk about the health ramifications in a little bit, in a few slides, but almost 20% of serious car accidents are associated with driver sleepiness. And that's completely independent of alcohol, whether or not alcohol is involved. The amount of time that Americans sleep has decreased 20% over the last 100 years. And people with chronic sleep loss have been shown to be less productive. They miss more work. They're less productive when they are at work, and they're more prone to be injured. And let's think of some really big things in history that have been, after the investigation, have been contributed to poor sleep or fatigue. The 3 Mile Island nuclear incident, the Chernobyl nuclear incident. Do you remember the Exxon Valdez tanker crash up in Alaska? Asleep at the wheel, so to speak. Big chemical plant in India, Union Carbide chemical plant, one of the biggest in the world. Explosion about 5 or 8 years ago contributed to fatigue of workers who were being overworked and not slept. So it's a big deal, right? It's a big deal for your health, and it's a big deal for all of us. So now let's go specifically into sleep apnea. And I know, again, a lot of folks in the room and a lot of people online have been diagnosed with sleep apnea. Trying to get rid of that first, sorry. The definition of sleep apnea is a sleeping disorder in which your breathing is briefly and repeatedly interrupted or stopped during sleep. And sleep apnea causes both nighttime symptoms and daytime symptoms. Have you guys ever been poked by a bed partner telling you snore or you need to roll over? That happened to me on Sunday night, and my husband's a liar. There's no way that I snore. But he texted me on Monday and said, "Do you remember the snoring conversation last night?" I said, "No, I have no idea what you're talking about." But I think it's important to know it's not just nighttime symptoms, right? It causes you to feel bad in the daytime. You're more irritable, you have worse concentration, some people have morning headaches, more forgetful, fall asleep just doing average routine things. So a lot of symptoms both day and night, and a lot of downstream effects and problems. Having sleep apnea and having it untreated makes you more at risk for depression, diabetes, heart problems, high blood pressure, and then dementia, memory problems, and memory issues, cognitive issues. So I talked about in the introduction a couple of types of sleep apnea, and some people know they have sleep apnea and know what types that they have. In general, there are two types of sleep apnea: obstructive sleep apnea and central sleep apnea. We'll talk about obstructive sleep apnea first. Obstructive sleep apnea is by far the most common. Over 90% of people with sleep disorder breathing or sleep apnea will have predominantly obstructive sleep apnea. And this is when your airway or the soft tissues around your neck, your mouth, and the back of your throat can collapse into your airway and prevent air from moving in and out. So you're trying to breathe, but there's just a blockage of that airway. That's where the term obstructive comes from. The second kind of sleep apnea is called central sleep apnea, and this is one that's rarer. It is more common in certain patient populations or certain populations of people with health problems, and we'll talk about that. But in central sleep apnea, you're not even trying to breathe. There's what we call a loss of the neural drive to breathe, the loss of that signal from your brain down through your nerves to your diaphragm and your breathing muscles that says breathe every 14 minutes or 16 minutes or 12 minutes. So in people who have central sleep apnea, you're not even trying to breathe. The drive to breathe is completely gone. So what are the risk factors for sleep apnea? For both obstructive and central sleep apnea, the first four are the same, and they're heart problems, cardiac problems. High blood pressure, a heart arrhythmia called atrial fibrillation, and other heart rhythms as well. Heart failure or congestive heart failure, as we sometimes know it. Obesity. Sorry guys, but being male, sleep apnea is much more common in males than females, but that doesn't mean women don't have it. And age over 50, and I feel that one. So these are the risk factors for sleep apnea. Now, I want to talk specifically about sleep apnea and cardiovascular disease or heart problems. Patients with high blood pressure that's hard to control, meaning you're on 3 or more medications to control your blood pressure, and your blood pressure is still high, 90% chance of having sleep apnea. Once the sleep apnea is treated, blood pressure is much easier to treat. Congestive heart failure. I spent almost all of my nurse practitioner career in cardiology and heart failure. Patients with heart failure have a 75% likelihood of having some sort of sleep apnea. So for every 10 people with heart failure, 7 of them will have significant sleep apnea to cause symptoms. And interestingly, about half of them will have obstructive sleep apnea, and half of them will have that central sleep apnea that I talked about. Diabetes, stroke, any kind of heart arrhythmia, so any abnormal heart rhythm, slow heart rate, heart blocks, heart rhythms that cause you to need an internal or implanted defibrillator, and atrial fibrillation. All of those significantly increase your risk for sleep apnea, and sleep apnea significantly increases your risk for all of those arrhythmias. So it's kind of a catch-22 almost, a cycle between the two. So how do you know if you have sleep apnea? I'll poll the room here. How many people in the room have already had a sleep study? All right. So how many people who have not already had a sleep study based on the first 10 slides want to get one now? So the way we test for sleep apnea, you may start with a questionnaire at your cardiologist office, at your primary care physicians or nurse practitioner or physician assistant office. We have a couple that are very common. One is called the Epworth Sleepiness Scale. That's the one on the right of your screen here. And then one called the Stop Bang Questionnaire. These questionnaires are looking to see if you have symptoms or risk factors for sleep apnea that would trigger a provider, a healthcare provider, to say, hey, you need to go and have a sleep study. So once you have symptoms of sleep apnea or have a risk for sleep apnea, you may have one of two types of sleep apnea tests. The first one we call a polysomnogram. That's done in a hospital or in a sleep clinic lab like Valley Sleep. And you have a misconception that you're going to have to sleep in a hospital bed or on a gurney all night. They actually have pretty comfortable beds. I had a meeting somewhere in the Southwest a couple of weeks ago, and the meeting with the physician and the sleep team was on the bed of one of their sleep labs, so it wasn't being used. But they're comfortable. They want them to look and feel like a bedroom. But you do have a lot of wires and gadgets, as you see in that middle photo there. So polysomnogram in clinic or in lab sleep study is the gold standard way. And it's because of all these wires and the fact that a registered sleep technologist is watching you sleep and monitoring that study. And if a wire falls off, they're going to come in there and hook it back up. But they're not always practical, right? And they're not always an easy test, especially if you're being screened. The other option is in-home sleep testing. And these tests have come a long way over the past 5 to 10 years. There are several different ones on the market, and there are several ones that can differentiate between central sleep apnea and obstructive sleep apnea. So they can tell, even at home, whether your sleep apnea is from a blockage in your upper airway or from you just not breathing, not having the drive to breathe. And I believe the one that Lori mentioned that we're going to give away here tonight is one of the ones that's capable of differentiating. I'll let her correct me at the end if I'm wrong here. So once you have a sleep study, whether it's in lab or at home, in terms of sleep apnea, what we're looking for is what we call an apnea-hypopnea index. And you may have heard doctors or healthcare providers call that an AHI. So that stands for how many apneas or hypopneas. So apnea is when you stop breathing altogether. Hypopnea is when you have a shallow breath and your oxygen drops. So how many of that in combination do you have every hour? And that's how we rate how severe your sleep apnea is. So if your apnea-hypopnea index is 5 to 15, you have mild sleep apnea. If it's over 15, you have moderate sleep apnea. If it's over 30, you have severe sleep apnea. So how do we treat sleep apnea? Oh, I'm triggering somebody's Siri. I can't trigger my own Siri when I want to, but I'm triggering his. So how do we treat sleep apnea? It would be a whole talk to go through all the different treatments for both kinds of sleep apnea. But the main point that I want to drive home is in 2022, there are many, many treatment options for both obstructive and central sleep apnea. And if you've tried a mask before and hated it, or if you won't go get a sleep study because your brother, uncle, neighbor had a CPAP and he hated it, there are so many options. There's so many different kinds of masks. And they will really work with you to figure out if a mask is the right choice. And a mask is a great starting place, at least to try, because it's not a procedure. You don't go to the hospital. It's not surgery. It's a great place to try. And people who get a good fit on their mask and get their sleep apnea treated and can tolerate it feel so much better that they would never go without it. But if you tried and you just cannot wear a mask for whatever reason, there are other non-mask options. For obstructive sleep apnea, there are what we call oral appliances or dental devices, and they're made to pull your jaw and your tongue forward. There's an implantable device for obstructive sleep apnea called Inspire. And I know that Laurie and the Valley Sleep crew do a lot of really nice meetings like this and webinars about Inspire. And then there's actually an implantable device for central sleep apnea. And that's what I'm going to talk to you specifically about for the rest of our time tonight. So again, I'm going to poll the audience in the room. How many people know you have central sleep apnea? This loss of the drive to breathe, where you just don't breathe. So several of you. Okay. So I'm going to talk specifically because I work for Zoll Respicardia, about the Remedy system for central sleep apnea. So Remedy was approved by the Food and Drug Administration in October of 2017. It's an implantable device, and there are some flip charts on each table there. You can look at it up close. It's an implantable device that restores that signal that I said was lost between the brain and your breathing muscles. So it stimulates a nerve in your chest called the phrenic nerve, and it restores the drive to breathe in patients who have central sleep apnea. So we're restoring actually normal breathing. This is a little bit about what the device looks like. It's implanted very similarly to the pacemaker, and it stimulates that nerve in your chest. And that nerve tells the diaphragm to take a breath. So you're taking a normal breath at a set rate that's exactly like your normal respiratory rate. So we did a lot of clinical trials and research studies with Remedy. We've actually started 13 years ago. And again, we were approved by the Food and Drug Administration in 2017. So we've been at this for a long time. But our biggest research study showed a 96% reduction in the central apneas, so almost 100%. 78% of patients in our study said they felt better. They had a better quality of life. Their overall sense of wellness and health was much better. And we actually asked the question of every patient in our trial, if knowing what you know now, you had this procedure, the implant, you had a lot of sleep studies, a lot of visits because you were in a research study, would you do that all again? 95% of patients in our trial said they would do it all over again. And that speaks to sleep apnea in general, how miserable you are when you have sleep apnea and you're not sleeping. We have that data out to 5 years now, and this is just one screenshot of that reduction in central sleep apnea. So the big orange line on the left is the baseline central apnea index. I talked about the apnea hypopnea index. And you can see patients followed up at 1 year, 2 years, 3 years, and 5 years, almost complete resolution of their central apneas. This is a very safe and actually straightforward procedure. I'll walk through the procedure in the next slide, I believe. In our clinical trial, 97% of patients who went to the heart catheterization lab to have this implant actually had the implant successfully, which is a really high number in a research trial, something that's brand new that physicians are learning to do. And 90% freedom from adverse events. And what an adverse event was is just the same as adverse events for any cardiac or heart pacemaker. Occasionally there was an infection at the site. Occasionally there was bruising at the site. Occasionally there were 2 patients that the lead moved a little bit, the wire that stimulates that nerve moved a little bit. And all of those issues resolved without any long-term effects. So if I tell you what's good about it, I have to tell you the downside, right? The downside is very, very minimal, very straightforward procedure. And that gets to the first question that I hear a lot. And again, if you're at a table and this is of interest to you and you have central sleep apnea, that little flip book, you go to the page that says implant. Remedy is implanted in the cardiac catheterization lab. Now, chances are if you have central sleep apnea, you've probably been to the heart lab before, the cath lab before. Not everybody has, but a lot of people have. You've either had a pacemaker or a heart catheterization, exact same staff, exact same physicians, and exact same type of procedure. It's a same day discharge. Most patients go home after the procedure the same day. It's implanted by cardiac electrophysiologists. So those are the heart rhythm specialists that implant pacemakers and defibrillators. It's light sedation. It's not a surgical procedure. You're not knocked out or with general anesthesia. Very minimal sedation. And again, most patients go home the same day. The second question that I hear all the time is, well, how does this thing turn on? Does it have a remote? Do I start it with something at my bedside? And the answer is Remedy is completely automated. It's completely automatic. Once we let the leads heal in after the implant procedure, you'll come into the clinic with our clinical staff and your sleep team, and we'll program the device based on what the device monitors you for the past month. So when we first implant it, it's just in a monitoring mode. It's monitoring when you sleep and how you sleep and what positions. I can tell you how many hours a night you sleep on your left side, your right side, your back. And we program the device to be customized to what you need. So once the device is turned on, which is about 4 to 6 weeks after implant, the device will know every night to come on when it's your sleeping hours. So let's say you sleep between 11 p.m. and 6 a.m. every night. So we'll program the device to come on at 11 p.m. if it knows that you're in the right position for sleep. So we can program your angle. So a lot of people don't sleep completely flat. You sleep on a couple of pillows. Some people sleep at 30 degrees in a bed that elevates. We actually have a lot of people that sleep in a recliner or semi-recline. We can program all of that so that the device knows it's the right time of night and you're in your right, what we call sleeping posture. And then it will wait to see that you're still. Once it detects that you're motionless in the right position, the device says, okay, you're asleep. It has a pause to let you get to sleep. And then it starts delivering that signal, that therapy at a set rate of respirations, which is the same as your normal average respirations when you're not having the apneic events. But anytime you roll over to change positions, or if you get up to go to the bathroom, the therapy knows that. It pauses and it will restart automatically when you go back to bed and you're lying still again. How many people here have a CPAP? How many people put it on at the beginning of the night and about 2 o'clock in the morning, if you have to go to the bathroom, you say, I'm not putting that back on, I'm going back to bed. It happens a lot, right? You don't have to remember that with this therapy. It's automated to your personal schedule and your personal sleeping position. So another question I get a lot is, what does Remedy feel like? Does it shock you? Does it feel like a shock? So I have a couple of quotes here, and then I have a video of one of our patients, and she filmed this herself during COVID. So that's why that kind of the angle is a little bit off, but she does a really good job, I think, describing how Remedy feels. So we're going to listen to Shelley.
I do notice Remedy at night if I wake up. I'm usually asleep when it turns on. So if I get up to play Words with Friends or something to that effect, or just get up, I do feel it if I'm not asleep when it turns back on. It is not an unpleasant feeling at all. I just feel all of a sudden my diaphragm just takes a huge breath. And it doesn't shock you. It doesn't hurt at all. You just take a really deep breath.
I have never had a patient tell me that it hurts. A lot of patients that say, I want to feel it come on. So they fake it. They get in bed, they get hunkered down, and they just lay there and they wait for it to come on because it gives them that peace of mind that they're not going to stop breathing at night once we get that thing optimized. And they just start breathing with it. A couple of our patient ambassadors, Shelley's one of our patient ambassadors, a couple of our patient ambassadors say instead of counting sheep, they count breaths. So they just wait for it to come on and they start breathing with it. Now, caveat with Shelley that I tell her all the time, you can't say you wake up in the middle of the night and play Words with Friends, because that's completely opposite of what we tell people you should do if you wake up in the middle of the night. But at least she's honest, right? At least she's honest. So what if you think that you would benefit from Remedy? What are the steps? So a sleep study is first. Most of you who already know you have central sleep apnea have certainly already had a sleep study. I talked about the implant. 4 to 6 weeks after implant, we activate the therapy in a clinic visit. You don't have to go back into the sleep lab to have your therapy activated. And then after it's activated, we'll see you back in clinic and really make sure we're titrating it, what we call optimizing it, customizing it for you. After we turn it on, we'll see you back in 6 to 8 weeks, and we'll really make sure we download that data again to tell how and when you're sleeping and how the device is working. We'll make any tweaks that we need to. Usually takes a couple of those visits to get it kind of spot on and dialed in. But that's kind of the process. And we'll close tonight with talking about how to get in touch with Valley Sleep if you know you have central sleep apnea. And or if you don't know what kind of sleep apnea you have, or if you feel like you need a new sleep study, we'll talk about that when we end here. So if you do want more information on the Remedy system, there are cards at every table. And on the back of those cards, there's a QR code in our website. You can go to our website or you can scan that QR code, and that will connect you with our Remedy patient liaison. Our patient liaison, we actually have two now. One is a nurse who has been a sleep nurse for many years. She works for us full time, and all she does is talk to patients and clinicians about their sleep problems and about Remedy. The other one is a sleep technologist who's been a sleep technologist for many years and actually just joined us in the past couple of weeks. So if you do want more information, those are some really good options. Pam, our nurse, told me a few weeks ago that she spends on average, she tracks all this, she spends on average 42 minutes with every person that calls her. It might not be all in one phone call, but that's her average. And so she will take all the time you need if you know that you have central sleep apnea, and this might be an option. I know I'm the only thing between the people in the room and dinner, and probably the people online as well. I'm going to finish with a story about one of our patients, and then we'll finish up.
I've got about 3 acres, about the right size for us to maintain. Take care of the flowers. I got some donkeys out back. I feed, take care of them. Try and spend some time out in the shop, starting to build another race car. Some people fall in love with golf. I fell in love with racing. Started in high school and was partners in a top fuel dragster. About 4 years ago, I was diagnosed with congestive heart failure with 5% pumping efficiency. I was experiencing a lack of stamina. I had no energy. Sent me to a sleep study and found I had central sleep apnea.
He would just lay there and all of a sudden he'd stop breathing. And I was scared that he just wouldn't wake up someday.
The doctor told me I was having enough episodes per hour in the sleep study would make me a candidate for the Remedy system.
When I heard about the Remedy system, I was in hopes that it would just help Bob get a good night's sleep so that he could enjoy life again.
The procedure was kind of old hat after having defibrillator and pacemaker put in. Just another trip into the hospital for me. After we spent some time working with it, you don't even know it's there. The biggest thing I found with the Remedy system is her getting to sleep. She woke up the next day and said, "This is the first night's sleep I've had in a long time." I sleep good. I sleep good. And gives me the ability to be active again.
He's got more energy. We can do more of the things that we like to do together.
I'm looking forward to getting back into drag racing again. I see people every day that this system could help. Don't hesitate, because it has helped me greatly. I'm looking forward to being able to do things I wasn't able to do before, and a heck of a lot more enjoyment.
That's Bob. We call him Cowboy Bob. And we have dozens of those stories. I picked that one because of the donkeys, to be honest with you. But I'm going to leave you with one last set of statistics, whether you have sleep apnea or not. 25% of adults have sleep apnea. That number is obviously higher in this room and online. But if you walk in through the mall or the airport or the grocery store, 1 out of every 4 people that you pass has sleep apnea. 60% of patients with any kind of heart disease have sleep apnea. And the worst one is 85% of patients who have sleep apnea don't know it. They're still undiagnosed. So if you know you have sleep apnea, you're actually winning here. So I'm going to leave you with that. And again, if you haven't had a sleep study, you probably want one now, right?
Is there any evidence that after you have the implant, that your body relearns to run its own oxygen?
Right. So the question was, after you have the Remedy implant, does your body eventually learn to does it cure the disease? Does your body relearn to breathe on its own? And the answer is no. And we've had patients with Remedy for years. We go into the sleep lab right now and we start the study off without the therapy turned on. And you have very classic central sleep apnea. If we turn it on, it goes away. We turn it off, it comes right back. So it doesn't come back over time. It comes back in a few breaths with most people. So the answer is no. And then we're going to do a Q&A here, but I want to give a couple of things. Thank you so much to Valley Sleep Center for hosting us. This is their website, valleysleepcenter.com. And you can actually go on their website and click patients and then request appointment and you can connect. But Kendall, if you want to talk, we have an even easier way here.
So I'm
if you're live here in the room.
I'm the marketing director with Valley Sleep Center. Thank you so much for coming out tonight. Great turnout. Our team is out front. They checked you in. They will also set you up for a consult, an appointment with us. We can get you worked all the way through. And if you are a candidate for Remedy, then we can get you set up on that. So,
or any other therapy you may need.
Obviously, anything else. So we'll get you through the whole process. So we appreciate you coming out.
Thank you, Kendall.
One of the things that is really disturbing is most doctors have no idea what sleep apnea is. I had a nurse that came from for your insurance once a year. She sat down with me and asked me questions. She said, "You better take the sleep apnea test." All these doctors that go to 8 years, 9 years, 10 years in school, they don't, it's bad for business. That's what the problem is.
Yeah. I can tell you nurses are better. So for those of you online, the question was, one of the problems is that sometimes physicians don't really know about sleep apnea or the impact of it or how to test for it. And I think you're right. And I think that part of that is this prevailing concept that sleep apnea just means you're tired, that it just means you're tired and you're tired for a lot of other reasons. And that's why we do things like we do, is to just encourage people to get tested. Now, I can tell you as a nurse practitioner, specific to cardiology, I tested a lot of people for sleep apnea, and I had a lot of people that refused to get tested. And part of it is because they don't understand the impact. And so when you have that conversation and say, this is why you need to get tested, this is the impact. And the other reason is, like I said, they don't want to get tested because they say they'll never wear a mask. And again, there's a lot of other options. We've come a long way. So I do agree. I think there's a lot of work to be done, both in the general community and the medical community, around this message. And honestly, that's my job security. That's why I have a job, is to get that word out. Laura, do you want to take some messages from the chat before you have to sign off?